I'm very proud that I can show this data. And I would say this INSPIRE register is something that was, as you said, from the beginning on. And we have now the 12 months data of the first patients included in this study. We have a device that really takes the shape of the aneurysm. I think this is the thing what it describes best. Whatever is built, and also the flared shape for the neck is very important, as was said before. But I think that it takes the shape of the aneurysm is one of the things that fascinated me most on this device in comparison to the others. And the register was a prospective, non-randomized, multicenter study. And the really important part is all the patients were included so far with a steering committee, with an imaging core lab, and clinical events committee. I think this is very important to gain data that we can trust, because everybody has a series and everybody speaks about his own series, but this is really very well studied and has evidence. So, so far, 300 patients are enrolled in this register, and I think this is a quite good number to come with long-term data. 1 year data. We published 6 months data this year, and they were already very encouraging. But 300 patients is 300 patients, and 293 patients were implanted. So you see a few didn't were not performed, but in most of the patients it worked. And 50 patients had a 1 year imaging so far. As you can see, the age of the patient is 60 as normal. Mostly were female patients, nothing surprising in the study. And 98% of the aneurysms were not treated previously. I think this is very important. And 9% were acutely ruptured. So at the beginning, and a new device is always very hesitating to use it in ruptured aneurysms. But as we all know, it's very well the same if you have an aneurysm that is ruptured or not. And it gets more and more. So from the aneurysm location, it's the typical locations, mostly in the anterior communicating artery, middle cerebral artery, but also internal carotid artery, which means sidewall aneurysms in most of the cases, and obviously basilar artery aneurysms. 85% were in bifurcations. The size of the aneurysms, due to the sizes available, is obviously smaller, on the smaller side, but as was mentioned before, this is also most of the cases that we treat. So we can treat a lot of cases with this kind of 7 millimeter and below aneurysm size type. 94% of the aneurysms were below 7 millimeters in this study, and 15% were even complex shaped aneurysms, not only just round and berry aneurysms. I think it's also important. When you look at the adjunctive devices, sometimes you say an intrasaccular device, I don't know if it fits, especially in the wide neck aneurysms. You didn't need an intrasecond device for 94% of the patients. I think this is very important and encouraging. It fits, it occludes the aneurysm, it sits in the aneurysm, occludes, and that's it. Yeah, I think it cannot be better. Doesn't it changes its shape when you detach it. I think this is a very promising procedure. If you look at the cumulative fluoro time in this study, 24 minutes is pretty good, I think. Femoral access was mostly used, but also radial access, whatever liked better. And I think the resheathings per device were below 1%. I think this is also an important part. So when you select it good, you put it in, and that's it. The number of detachment attempts, I think sometimes you had to do it twice, but I think this is not something what we are not used from other devices. Duration of antiplatelet therapy. I think this is always a question. We pre-medicate our patients with dual antiplatelets to have all options in the procedure. We started with that. If there is contraindications, we don't do. But see in the study, there is a lot of different kinds. 19% had no antiplatelet medication at all. Yeah? And single antiplatelet therapy was used in 56%. I think this is also something that is very, very encouraging. 75% of the patients had no dual antiplatelets after the procedure. Is also impressive. It was stopped mainly after the procedure or after a week. Later, depending on the size of the neck, a little longer, maybe 1 month, but very, very short term. We saw complete and significant stasis in 75% of the patients post-procedure. So you don't see a complete occlusion after the procedure, but a significant stasis. When you do a control in the first post-operative day, usually it's gone, or at least very, very reduced in flow. The neurological adverse events, if you look at major stroke and in the territory and neurovascular death with 1.7%, this is what was shown before in the range of the other devices. I think this is a very good, safe therapy. And concerning the image modality, we allowed everything because the standard of the register was to use that what is used in the hospital always. And as the imaging quality gets better and better, not all had a DSA, but we switched now to have really severe and good data. So far, only 50% or 54% of the patients had a DSA. But still, I think that also is addressed from the core lab. If they couldn't determine very nicely a small neck remnant, because in the MR there's a small artifact or so, they called it cannot determine. I think it's not that they couldn't say it's completely open or it's completely recanalized, but they couldn't see a small neck remnant due to the small artifact. And then they called it not determined. Nevertheless, in the 6 months follow-up, you see 64% complete occlusion, which is very nice. And if you look at the 1 year follow-up, still, and I think this is important, we have a 60% complete occlusion. Yeah? If you exclude the not determined, it's 73, but that doesn't really help us. I think the adequate occlusion at 1 year is 85% with this device. So far, very encouraging. The recurrence and retreatment rates in this study with 300 aneurysms so far, there was no aneurysm so far was identified with recurrence. 2 patients had to be retreated, and if you look at the images of these patients, they were too small sized. I think this is very important, and they were on the larger side. If you look at the follow-ups, obviously all the patients were in a good shape at 1 year, and the key takeaway messages. I think this is the important part of the study. What we wanted to hear is you have a major stroke and a morbidity mortality rate of 1.7%, which is really good. I think the overall safety, when you can see 96% implant success, 97% device placement success, conformability to the aneurysm, almost 98%, almost 100%. I think it's safe. And it's easy to use, and with 60% complete occlusion, it's also very effective. So recurrence rate with 0%, that's all what you wanted to know after 1 year's data, and I think we are still collecting data and are very encouraged to see the next follow-ups include more patients. Thank you very much.
Okay, thank you very much, Monika. So if we summarize, we have roughly 60% of complete occlusion and 80% or 80% of adequate occlusion rate, which is very encouraging, confirming the high efficiency of the intrasaccular devices. How would you place the treatment with an Artisse? It's bifurcation aneurysm, roughly below 7 millimeter?
Roughly below up to 7 millimeter, I would say. Especially the small ones are very nice because it's not so nice and easy to get a small catheter into a 3 millimeter aneurysms and then a coil and maybe another stent or so. A small, tiny Artisse putting into a 3 millimeter aneurysm is really, really something that feels good. It feels safe. Yeah? And I think this is the key point. You can use it for almost all aneurysms. It doesn't matter if it's a wide neck, a small neck, a sidewall, or a bifurcation aneurysm. I would say you can use it for all of them, ruptured, non-ruptured. The only thing is you need to select it well and occlude the whole aneurysm so that it really can adapt also to different shapes of the aneurysm. The only thing what is maybe at the moment to be careful is the very shallow aneurysms. So the really ones that are very small in the height and wide in the neck. At the moment, from the sizing portfolio that we have, these ones are the ones that I would not treat. But all the others you can treat very nicely and very safe. It saves also my coronaries.
Okay, so I have also seen that most of the time there were no adjunctive devices being used, which confirmed the fact that the engineer, they have invented those intrasaccular devices to make it simple, meaning that you use the Artisse by itself. And I have also noticed that most of the aneurysms, they were not previously treated, meaning that it's not that obvious that you could use an Artisse after a recurrence after coiling. Is that what you want to say? Or?
I think it is a very interesting finding. We need to follow that more in detail, I would say. But in the study, we realized that all the thromboembolic complications that occurred were in patients that were not pre-treated with antiplatelets. That was something I wasn't so aware of. And I think, as I said before, most of the people treat anyway with monotherapy or dual antiplatelet before they decide what to use. Yeah? And I think, I wouldn't say it's a recommendation, but I would say it's a good idea to have antiplatelets 1 to 3 days before the procedure and stop it after the procedure when it's really treated with an Artisse. I think this is one of the things we learned in the study.
Let's talk about antiplatelet treatment for non-ruptured aneurysm. What's your feeling about, so I have seen that most of the cases, the antiplatelet treatment was stopped after the placement of the Artisse. So what's your insight regarding antiplatelet treatment in the use of the Artisse?
I would say if it's a, so to say, smaller neck size and it fits very nicely, if only the small marker protrudes into the parent vessel, you can stop it after the procedure. When it's a wider neck and it comes down a little bit more to the parent artery, I might leave it a week or a month. Yeah, this is more a gut feeling than a real scientific saying. But I think this is normal, that you leave it maybe a little longer. I wouldn't leave it longer. There's no need for that. Because we have also seen very nice in the animal study, as you have shown before with the web. It's a very nice endothelialization coming from the side of the vessel across the neck. There's a very nice basis that can take over a new endothelium. So knowing that, I think I trust it. And when you leave it on dual antiplatelets very long, you might keep it too long open. No need for that. Yeah? So you can stop it.
Cyril, I have a question for you. Probably you will address this point, which is the protrusion of the device, which is a non-terminated question mark. So how do you manage protrusion?
To be honest, at the beginning, I was afraid of the protrusion and I was not allowing a bit of protrusion. But now I accept the triangle part of the device, the proximal triangle part, for me should be at the level of the neck, beyond the neck, sorry. So if, for example, you use the high incidence, you have the high incidence and you will be sure that the aneurysm will be completely occluded if you have the triangle part, which corresponds to the proximal part of the device inside the eye. So I think you have to accept a bit of protrusion, yes, to be complete.
Monika, coming back to you, maybe you don't have this information yet. Do you have any insight from the core lab about the so-called deformation of the Artisse after its placement, which is belonging to the healing process? If I'm looking to the web, the clot and the healing process induce a deformation of the device. So do we have any information about that? How can you say to those people listening to us that maybe they will have a deformation of the device without an angiographic recurrence?
I don't have the full information, but I know that Jens Fieler, who is the co-lab, the group is working on that. We have seen slight deformation in some aneurysms, but as you say, without recanalization. And I think this is very, very important. Maybe we need to follow up more longer and more aneurysms, but I think if it occurs, it seems not to harm. Yeah.